Josh and I have the tremendous privilege and opportunity to interview Dr. Adam Chaffetz. And first of all, I want to welcome you to the continuation of our session on managing chronic pain. And, this is so important because it impacts every one of our lives. As I'm sitting here, I can sort of feel a little bit of tension in my own back here. Over the past month, I've had some real pain issues dealing with my parents who are 90 years old. So it truly does impact every single one of us. First of all, I would like to introduce you to Adam Chaffetz, who's, actually he's a chiropractic neurologist. He's the managing director of our multiple sclerosis center here on campus. You've been working about greater than 10 years or so,
12 years.
Leading the program. If I remember correctly, it's perhaps one of the largest programs, or is the largest program in Northeast Florida.
Yeah, we're very fortunate to have an unbelievable director, Dr. Scott Silliman, who started the MS Center 16 years ago. So we are the premier, largest comprehensive multiple sclerosis center in this geography for quite a distance.
Right, and I can see you add so much to the program because of your background and as a chiropractor. You've had private practice and you've had multiple modalities, a professor in teaching massage therapy, myofascial release, multiple different interventions or integrative or alternative interventions, which can complement, the work that they're doing up in the center. And I just know over the past years, you've just been a tremendous advocate for patients. That's been your passion probably for the past 30 years or so, is to advocate for patients, who are suffering chronic disease like multiple sclerosis. But I think you are the perfect person for us to take this chronic disease and help us to understand more clearly how pain affects each and every one of us. And, specifically multiple sclerosis, I have a very rudimentary understanding, but really it is an autoimmune disorder that basically attacks the myelin sheath, which enwraps the nerves. And I was sort of thinking like I have a cable or an electric wire, and that sort of wrapping around the wire protects us from the wire, but also allows the current to pass down the wire.
Right.
But if we rip that wire, the sheath around it, then we're not going to be protected, and we're going to have major issues with that. Explain that a little bit to us, sort of give us a good idea of how it impacts chronic pain, how it impacts patients who have MS, and how we can apply that, to our individual lives.
Sure. So as you mentioned, multiple sclerosis is an autoimmune disease, which simply put, the body is attacking itself. And so in the case of Crohn's disease, it's the GI tract. And in the case of rheumatoid arthritis, it's the joints in the hands and sometimes the spine. In this case, it definitively affects the central nervous system. And that process of demyelination, what that does is it causes the cord that you described. Imagine a mouse every night coming out and chewing a little piece out of it.
Exactly.
And so by the 30th chew, the mouse is going to probably chew through the cord, through the copper wires that are underneath that plastic. When patients suffer this type of demyelination, and there are other diseases that can cause it too, like Guillain-Barré, for instance, it can cause pain along the whole pathway of the central nervous system. So from the sensory aspect up to the thalamus, which is where pain is usually interpreted. You can have lesions in the central nervous system that are going to be activated by that demyelination. So when we see patients that have MS pain, it's a little bit different than a person working in their yard, bending over, hurting their back, and having an acute pain. This is pain that that really sometimes can be very, very severe and not super controllable for a lot of patients.
Yeah, and I can see where, I mean, as you described, affecting, that copper wire or our nerves that are going the whole pain track, as you might say, if you please, from the brain always all the way down to our toe. It may affect that nerve, but when the nerve is affected, it affects the muscles. And then our muscles are wrapped with something called a fascia, and that attaches to the joints. And that whole combination or that whole complex system is affected. And it really impacts how we treat the pain. We may focus on the nerves, but we also may have spasms and that type of thing, which causes more pain. And it really can develop a horrendous sort of cycle. The more pain, the more spasm, the more inflammation, and then more pain. You get this, sort of cycle that goes on. Is that sort of a proper understanding of that?
It is, and so it gives me an opportunity really to tell our audience a little bit about the difference between like the term spasm, when you hear the term spasm, and then the term we use clinically, spasticity.
Okay.
So for instance, you see stroke patients in the ED, you see patients that have strokes, and when they have motor areas that are affected, sometimes what you have is spasticity that is a result of the damage to the central nervous system. In multiple sclerosis, so many patients, more than less, at some point will have this spasticity. Now, what is spasticity? Imagine tightness in your thighs, not just tightness, so severe and painful, it prevents you from walking. Okay, so we have patients that have spasticity that's so severe, they literally have to have pumps implanted, which goes directly into their central nervous system, because that method of delivery is so much less than they would take orally, because they would have to get up to taking so many medications.
But the same thing sort of goes on for you or I, or those patients I see in the emergency department who have back pain, and they get pain sort of shooting down their leg.
Right.
That can cause spasm, more inflammation, and we get in sort of a same cycle. It may not be on the chronic level, but we can get in the sort of the same mess, so to speak.
Well, when you have it, you're not really wondering what it is. You're wondering how you
Exactly.
can get out of it. And in terms of just plain spasm, think of spasm, when we think of it in the clinical sense, as clinicians, we want to reduce it, but think about it as a protective mechanism. If you bend over the wrong way, you lift something that's too heavy, you twist the wrong way, and your body is impacted by that, your back goes into spasm as a protective mechanism so that you stop doing the motion.
Okay, got that.
to guard the area. So when you think about spasm, think about muscle guarding. Okay, now muscle guarding can be reduced by using anti-inflammatories for the inflammation. And
That'd be like something like Motrin and
yeah,
ibuprofen, for example.
and then you're going to use a muscle relaxant for the spasticity. And then if you're comfortable with that, that may reduce the pain complex. So a lot of times when we see patients either in a chiropractic office or even in a physical therapy office, what we see is a patient hurts their back, goes to an urgent care clinic, and then they're only given a pain medicine. They're not given anything for the spasm. And so what we're talking about here on my slide is the only effective way to treat a condition is you have to identify the source of the pain. So if the pain is spasm and it's related to a disc problem, you have to take measures to reduce the disc problem, but you also have to treat the spasm at the same time. So we may use, in a medical model, we may use multiple medications, as we just talked about. Now, even if a person goes into physical therapy or a person goes to a chiropractic office, they shouldn't refrain from using medicines. They should use all of the components in their quiver that are going to be helpful to get them back, on track. So generally speaking, the severity of an injury is going to depend on whether there's a source of radiating pain from where the pain starts. So if you have a neuropathic type pain, and you as an ER doc probably have seen diabetic patients with neuropathic pain, sciatica is a type of neuropathic pain. So these are usually treated by, believe it or not, seizure medicines.
Oh, wow, that's interesting.
So we use a whole armamentarium of different medicines like gabapentin or Lyrica to decrease the severity of that neuropathic pain. Now, when you have clinicians like Dr. Silliman who are at the top of the game, he realizes that pains can sometimes cause depression. So he might choose a medication that will cover both aspects. That'll cover depression as well as pain. And so that's really the best treatment approach to treating chronic pain, is understanding that any pain that lasts for longer than 3 months is going to grate on you.
Right,
It's
right.
going to grate on your psychology. So if you don't address the psychological aspect of it, you're kind of like a football team that doesn't have a running back or a tight end.
Okay, and that's sort of interesting, you know, and when I'm in the emergency department, you bring it out, you got to sort of make the diagnosis and look at the multiple modalities, and we're going to get a little bit in
Sure,
all the modalities that we're looking at. You know, quite often in the emergency department, I'll have a patient who comes in and their pain sort of seems out of proportion for what it might be. You know, they just leaned over and picked up a plate out of the dishwasher, for example, and they can hardly move. They can't even get out of the gurney, for example. And I've learned, you know, this concept called amplified pain, meaning, and that's sort of that cycle we were talking about. You know, the more pain you have, the more inflammation, the more spasm. And you've got to break that cycle, and you can break it in the multiple different areas. Tell me just a little bit about that amplified pain cycle.
Okay, sure. But before I do that, let me just mention the difference between acute pain and chronic pain. Acute pain is if you bash your hand with a hammer, and it's what you feel right then and there.
Got it.
And hopefully 24 hours later, that pain is gone, depending on how hard you hit yourself. Chronic pain is something defined as pain that's been there for 3 months or longer.
Okay.
So we see patients all the time as chiropractors that have been in car accidents. Like myself, I had a car accident 17 months ago. I'm still having problems from it.
So you had acute pain right when you were in the
well,
accident.
yeah, it was severe
And then
acute
the
pain.
pain persists, and that sort of moves into the chronic stage. So you may have acute on chronic pain, which may, you know, impact how we treat the
And then
process as well.
let's say you're like 80% of Americans that are going to have a bout with low back pain sometimes. Let's say you just have a bad back and you decide to go out and wash your car, rake the leaves or something. Well, what that's going to do is that's going to cause an acute aggravation of an old problem. So you have to treat that like an acute injury until we get them back to baseline. And hopefully you can. Now, if you want to go to the next slide, we can talk about amplified pain syndromes. So these are conditions that really perplex medical physicians.
Because again.
And the reason is because we're so evidence-based and we want objective documentation of what we're dealing with. And these syndromes don't fall squarely into that mold. Take fibromyalgia, for instance. It's a completely clinical diagnosis. You have to have 12 points. They have to be in a specific area. Usually, and I've had plenty of experience with these patients because they usually have been to many specialists and have been told either there's nothing they can find, or even more harshly, they've been told there's nothing wrong with them.
Right.
And so that is a bad diagnosis for somebody who's already depressed from chronic pain.
And that's why I try to validate the pain, because it's real pain.
Exactly.
I mean, in the emergency department, you know, and we get so frustrated. But the validation, I think, is perhaps one of the most powerful things that I can even do in the emergency department. I may not be able to completely shut it off, but at least I can validate and then begin to get them on the right path, helping them to understand that, yeah, they're going to have to essentially rewire their brain. They've got to sort of rewire their whole pain system, so to speak, in order to break that cycle we talked about.
That's exactly right. And this, this happens to highly intelligent people. I had a patient who was a physician assistant. She was debilitated by it.
Okay.
She could not work. And I said to myself, this is a lady who has all the clinical knowledge, but she has so much pain that she literally can't work. I tried to get her on an exercise regimen. Honestly, it was a very difficult management tool. She just was probably one of the most complex patients I ever treated. And the success rate honestly falls with the patient, because they have to take ownership of wanting to get functional with getting this condition in a manner that's controllable.
Perfect. Now, obviously, what we're looking at here then is that, yes, medications are quite helpful, but there are non-pharmacologic interventions that we can utilize as well. And we've all heard those terms: complementary medicine or integrative approaches. Those things which we can add on or supplement, or adjuvants, perhaps is the word. You're the specialist in this. Tell us a little about all the modalities, or some of the modalities that we can potentially use to sort of rewire the brain and to help us.
Sure. So when we're talking about, and let's talk about soft tissue injuries, okay? Soft tissue injuries could be back, it could be neck, it could be athletic injuries. I mean, I've had the unbelievable honor of treating many professional athletes, because my practice was in Ponte Vedra, and I was literally embedded within the PGA Tour headquarters. So I've treated a lot of professional athletes. And I tell my patients, consider yourself a professional athlete. You want to stay in the best shape, and they're all about function. They try to work through the pain because they're all about function. So they have to go to a person that is astute about their specific condition. So I was a professional athlete, so I was able to draw patients like myself that had that understanding. Because I also live in chronic pain, I have a little understanding of that too. So what we do with these patients is we formulate a plan which is going to be finite. We're going to say, okay, for this period of time, we're going to do this number of treatments. I want you to do these exercises. I want you to consider dietary changes, because we're looking at your diet and we feel like it could be contributory to some of your symptoms that you're having. Now, some of the modalities we use are going to be hands-on modalities like massage therapy or myofascial release or neuromuscular therapy. So when you take that person who has fibromyalgia and these tender points are there, you can't go in there and use pressure on those points like I would one of the Jaguars. Because of that amplified pain syndrome, their threshold for pain is so much lower that you have to augment your treatment technique to that person's condition. So when I was training massage therapy students, physical therapy students, occupational therapy students who deal with professional athletes, that's easy because they want you to kill them. But when you're dealing with hypersensitive patients, like patients who have neck problems, back problems, sometimes more pressure isn't always the best way to go. And so there are techniques like myofascial release, positional release. These are all very subtle techniques. Sacro-occipital technique is used for headaches, for chronic headaches. And so we use acupuncture. We use dietary changes, supplements sometimes that are known to have an anti-inflammatory quality, which helps not to stop the disease process, but to control the effects of it.
So as a physician, I have a whole armamentarium of people that I can potentially, or specialists that I can reach out to. And you
Absolutely.
mentioned occupational therapists. You mentioned physical therapists. We have massage therapists. We have a
Sure.
chiropractor, especially people like you who have
Right.
a specific specialty. They may use in physical therapy TENS units and those type of things to potentially help. There's osteopaths, you know, that have trained specifically on, you know, dealing with you know, muscles and fascia and helping us sort of regate that pain mechanism.
Exactly. So there, and it's really difficult because, I mean, I want you to think about it from a patient standpoint. There are probably 7 different providers you can go to for back pain.
Right, right.
And so everyone has a little bit of a different approach. It's kind of naive to think that maybe a couple of them couldn't work together, you know? And so I have a really wonderful relationship with the physical therapy department here. We have some wonderful physical therapists. I mean, some of the best in the business, to be honest with you. And how do I know this? Because I've been working with them for 12 years
Right,
plus.
right. Okay.
And so we definitely have programs within the house here that can help patients. I would like to see chiropractic come on board eventually. For the time being, we have a provider, Dr. Alan Halpern, who does acupuncture.
Right, right.
We are offering massage through the wellness program, probably more so in the future than right now.
Right, right.
And so I just want people to know that sometimes you have to educate your doctor. Like if you've gone to a good provider, I used to hear from my own patients. My doctor wouldn't refer me to anybody because they didn't know a good chiropractor. So the first thing I did when I established my practice in Ponte Vedra was to establish with the primary care center.
And help them know.
And so I literally became the neurologist for Ponte Vedra for the 20 years I was there because, as you know, they don't have one.
Right.
So
Okay. I want to change factor just a little bit. I know that we're all at work here.
yeah.
And boy, if I'm sitting in my chair for 4 hours where I should get up and move and do that type of thing, give me some hints of
Okay.
things that we can specifically use.
Okay.
Workplace hygiene, I think it's ergonomics that, you know, we can do. Tell me a little bit how I can sort of be more preventative, even prevent this pain cycle from getting launched in the first place.
All right. So while we're at work here, and let's face it, we spend a great deal of time at work. We're all very dedicated to UF Health, and our jobs at times can put us in stressful situations. So what I tell people to do, this slide is a perfect example of some of the things that I want people who are listening in to adhere to. The first thing is obviously look at your workplace. If it doesn't look like the figure that you see here, then you need to have somebody look at your workplace and adjust it. My physical therapist, Dr. Scott Fortney, literally came to my office and saw my setup.
Oh, really?
And gave me some tips on what I could do. The other thing you want to do is, if you look at the diagram about lifting, I want you to think about if you dropped a quarter on the floor, would you lift like you're lifting a box? Well, you need to. You need to. And the reason is because lifting improperly, it doesn't matter what you're lifting, it's how you lift. When you lift in an improper posture, that is going to be the straw that breaks the camel's back that's going to cause the back pain 24 hours later in your emergency.
So that's the guy who
That's
comes in
one of the mechanisms. And it's usually repetitive. What do? They lift and then they start doing activity and they don't feel it until they're done, which is usually 12 to 24 hours later.
So the trigger guy who leans over and picks the plate out of the thing, I said, that's hardly anything.
Exactly.
It's the mechanism that he used.
Yeah,
It's
a lot of
improper technique.
A lot of times.
Okay.
And then when we're at work here, we're somewhat limited. I mean, people on the north side have that beautiful gym that they can work out in, but here, what I do is I bring a good pair of walking sneakers. I walk every day, try to do 2 miles every day here at work. I try to take a couple minute breaks to stretch. And I also just put on some calm music and breathe every once in a while, especially when you've had that encounter with a patient or just a negative situation. And then for those who ask me about sleeping posture, look at the picture on here. If you take a towel, roll it up, put it underneath the base of your neck and your shoulders in between, that is the perfect pillow for you. When patients ask me, what kind of pillow do I buy? Take the pillow you like, put it over that roll, and that will be your perfect pillow.
That's interesting.
Yeah.
Okay. Now, there are other lifestyle changes that we can potentially do in order to break that, so to speak, that cycle. And obviously, sleep has a big impact. Nutrition, which you've mentioned, dealing specifically with our stress, and also exercise. Let's start with nutrition. We got about 4 minutes. So,
Okay.
Just inflammatory diet. That's probably the thing. Now, we have a nutritionist here, John Bredenberg, who, he reminds us about multiple things to impact. But I guess the sort of the basic things that we can do is, one, decrease the amount of simple carbohydrates that
Absolutely.
we have. Do you ever use, and then trans fats, we'd like to eliminate that from our diet, or saturated fats, where saturated fats come from, I assume, it's like meats and red meat and that type of thing, which are, quote, pro-inflammatory. A lot of people, when you can't make big money on doing all these big research studies on diet, so that may be why we don't have as much evidence in this area. But in your interventions, do you use diet to help your patients, MS patients, and your patients in your private practice, concierge service?
Yeah, because there are actually doctors of chiropractic who are specialists in nutrition. So I would probably consult with them over, given their condition. But there are some diets out. The Wall diet, for instance, is an anti-inflammatory diet specifically for MS. And like you had mentioned, if they go and they do some research, you'll be able to see that there's more and more that's being uncovered about, especially neural inflammation.
Right. Okay.
And so diet is becoming important, but I don't think it takes a genius to realize if it's in a package, it probably isn't good for you.
Or I always say, if it's white, keep it out of sight.
Yeah,
and that's all that sort of bread, sugar,
decades,
all that type of thing.
Yeah.
Now, sleep, we do know sleep, and we've, I've given some talks on that in the past. 7 to 9 hours of sleep is essential. When I only do 3 hours of sleep because I've worked overnight,
right,
that's not a good thing. And I do get headaches after that. I get neck pain. So I'm sure you stress that in your MS patients as well.
Absolutely. So sleep is super important because, as you know, sleep disorders have comorbidities, and they actually can be very, very serious if you don't get sleep. So what I tell people is, you just try to alter your schedule. I think people generally stay up too late. And I had to learn how to go to sleep early and get up earlier. And by altering that schedule, it allowed me to get the 7 hours that I'm getting now, as opposed to the 4 hours that you're getting.
Yeah, well, it's that sort of light at night. We, keep our television on,
Right.
We have our cell phones, our rooms aren't dark, it's not cool. We really need to develop a ritual as far as going to bed, turning those lights low, getting in a very comfortable place, not be cluttered with televisions and all of our, technical support,
Sure.
in our bedroom, which might be hard. Now with COVID, there's so many people are having to work at home, but we
Yep.
really need to be cognizant. And probably just in conclusion, exercise. We know exercise is really important movement. Tell me just a little bit. I know y'all use Tai Chi and those type of things, massage therapy, yoga, all of that in your practice. Just sort of bring me up a little date on that.
Okay. So when it comes to exercise, I mean, even the most debilitated MS patients, we encourage them to move, because without movement, you're going to get deconditioned. The deconditioning is going to cause motor weakness. It's going to contribute to pain syndromes. So you have to move, you have to exercise. And one of the things about overcoming chronic pain is having an activity that's going to take your mind off the chronic pain. So being a surfer, my car accident really impacted my ability to surf because I can't put my neck into extension any longer without having really significant symptoms. So I also have a paddle board, which allows me to stand up and essentially do a similar activity. While it's not perfect, it allows me to get the exercise that I love in an augmented fashion so that I can continue to enjoy it, something that's physical in nature. So I tell people, find something you enjoy doing. And like COVID has really impacted people going to the gym. So this is why you need to get outside, pick an activity you enjoy, kayaking, rowing, bike riding, even if it's stationary, chair yoga. There are plenty of programs that you can do now virtually. So my best advice for anybody is be like a professional athlete. These folks train, and their performance is not haphazard. It's due to repetition. And that's what exercise is good for. You repeat doing the same thing over and over again, it's going to take your mind off the pain and it's going to make you more productive. So like my slide says, your attitude plus your activity is going to equal your level of achievement. So you want a good attitude with the right amount of activity, and that will achieve your end result.
Well, great. Well, thank you so much, Adam. So
My
just sort of in
pleasure.
summary, things I've learned, there's a significant difference between acute pain and chronic pain. Chronic pain quite often can get amplified or sort of out of control.
Sure.
So it's a cycle that we need to break, and we have to use multiple modalities. Yes, we may use medications, but there are non-pharmacologic modalities that we may use: physical therapy, occupational therapy, manipulative therapy, behavioral management, and that type of thing. But there are also a lot of lifestyle things that we can do at work. We can make our work environment healthy, meaning, set up our desk in the proper way, get up and do that type of thing. We do need to think about, our diet. We need to think about, getting adequate sleep and making our room supportive of adequate sleep. We need to exercise, and we obviously, need to deal with our stress as well.
Yeah.
Great advice, and I look forward to applying it in my own life. Well, thank you so much.
Thank you.
All right. I don't know if there's any, let me just look at the chat session and see if there's anything else. If not, we will close out. Are there any questions? I don't see any questions. If you have any questions, shoot them on there. Otherwise, we will close out. Thank you so much for listening. And we look forward to our next event, which will be next Thursday, as we deal more with the medication side of things and looking for efficacy as well as side effects and that type of thing. Thank you so much.